Hello, welcome to Wellbeing. I'm Guy Murphy. Today my guest is Dr Hazel Dalton, who works at the Rural Health Research Institute at Charles Sturt University in Orange, and we'll be talking about community wellbeing initiatives. Thank you for joining me on the show today, Hazel.
Thanks very much, Guy.
So first off, what got you into this line of research?
So I started working in rural mental health in 2014 when I joined the Centre for Rural and Remote Mental Health. And in 2016, we were looking at the rates of suicide in rural and remote Australia were about 50% higher than in the cities. And to draw attention to this growth inequity, we actually gathered a bunch of experts from health, from research and from policy and government together at a forum at the Royal Easter Show to talk through that. We brought a discussion paper to them and talked through the challenges, gave them time to think about what it looked like in different sized rural communities, and essentially had a big discussion and took down their feedback and pulled together with other evidence a position paper on suicide and its prevention for rural communities. And one of the focus areas, so the focus areas we described for rural, which is, for resource lean environments, were to think about supporting people who experience suicidality to stop taking their own lives, but to also help those who are bereaved by suicide, to pay particular attention to vulnerable groups, to also then think about building protective factors in children and young people. And the fifth area of focus was to build healthy and resilient people in communities. So that fifth area, that upstream prevention, was really the space that got me into this area of work. So we had that side of, policy sort of influencing space, but we also had the real challenge of working with a community that was actually in crisis, had a number of suicides, and there was real concern about what to do about it. And their director of mental health realised that it was a problem that went well beyond the health boundaries and it needed a community-level solution. So in 2016, we worked with the Clarence Valley, talking to members of the community, gathering as much evidence from the public data systems as we could, and also then drawing upon literature in public health and prevention side to give some advice. But when we drew together this report, took together with the community around a workshop saying, what would you like to do? They formed their own governance and network and opted in to have a community coordinator that various organisations funded. So it was a real collaborative input, and they set about forming our Healthy Clarence. And they were very deliberate about not calling it a suicide prevention network or things like that because they wanted to go in the direction of travel. So I guess those two key parts sort of set me down that path. And we also had the opportunity with the New South Wales Mental Health Commission supported us financially to go in and support the Clarence Valley after that to do an evaluation, and we were asked by them to do a scoping review on what collaborative approaches to community wellbeing looked like and what the literature said. So we did an initial scoping review in 2018 and produced some resources to help communities, address this, and I think we had some opportunities to work with some other communities around this. So that's kind of the backstory. The reason why I went back and did a rather comprehensive lit review and conceptual paper was at the end of the experience of working, I think, with about 4 different communities. And in this space, one of my colleagues came back to me and said, Nick Powell said, if I had the chance to do it again, I know exactly how I would do it. And I think the other reason was we had this idea that a lot of the time communities didn't just want to know what to do, they wanted to know how to work together, like how do people do this successfully. So that second review was really about sort of that mechanics of reverse engineering what successful initiatives did and how others could follow that path.
Okay, fantastic. So the one that you just mentioned, the sequential review, is that the Co-Creating Community Wellbeing Initiatives study that you're referring to? Okay, fantastic. What motivated you to conduct a review specifically of community wellbeing initiatives rather than more clinical mental health interventions? The prevention versus intervention, I suppose.
Yeah, I think because you need both. And it's often not a clinical crisis for people. Obviously, if someone dies, this is very serious health risk, but there are a lot more determinants in someone's life about things, stressors and other things. And I think in a public health sort of sense is we need to act in the crisis situation, but we also need to plan to support prevention, going more upstream rather than being the ambulance at the bottom of the cliff, if you know what I mean, to mix my metaphors. But the idea is then, when a community is in crisis, you also have the risk of those who are affected by suicide, and you need to start thinking about how do we as a group take care of each other, and how are we better at recognising the signs and symptoms in each other. So I think the community level, and particularly a place-based approach, is actually rather vital, because rural communities are often resource poor. We can't just magic up more services, and to think about all the ways that we have at our disposal and how we can collaboratively work to maximise our strengths and to leverage into free resources or advocate for better is actually really important. And I think that sense of agency and control is really important for the collective outlook and belief that they can be healthier and better.
Yeah, absolutely. You're listening to Wellbeing. My guest today is Hazel Dalton from Charles Sturt University, who is a researcher in community and wellbeing. And so in the study, you present a matrix of 8 key themes associated with successful initiatives, which, just to quickly go over those, were community alignment, community ownership, engaged community, shared purpose, collaborative action, transparent communication, continuous learning, and resource management. And which ones of those did you find sort of the most common and or the most successful, when implemented in community initiatives, and why?
Sure. I guess one of the things I would say is these are things that work, together with each other. It's kind of like identifying the principles of operation, so they don't really disengage that much from each other. But what I will say is I think you really want to have a sense of, so if you have a coalition of the willing, like people with a vision on what they want to do and a can-do attitude and significant advocacy, you can, leverage a lot, and if you recognise the volunteers or people who have roles that fit in with this way of working, you can leverage a lot from what you've got. And so I guess things that you want to do is leverage off your local assets, get a collaborative group together, try and make sure that you've got the right people in the room, and if you don't, go and have those conversations about why they should come along. And you can do a lot as an engaged community. I think when you want to sustain it, you then really have to then think about the resource management. Is how can you make sure that those people can still keep going? Is there a way to get some resources, whether they're in kind or monetary, to keep going? Because it's not... This takes time and it takes energy. And I think one of the things that happens is to have sustained activity, the community needs to start seeing and understanding what you're doing and see the results of it. So the other things that come on board is around communication and measuring and like learning what you're doing, and sort of the evaluation communication piece becomes part of the thing that allows you to leverage for more money, to have an engaged community because they can see the actions and they believe in it and they come along as well. So you see these all start to work in with each other. But in the initial stages, I guess one of the things is really around having a group of people that recognise the challenges that you wish to address, know what the local community strengths are, and are willing to work together to do some work in the community.
Okay. Just a little bit more on that note, you mentioned that you have to have the right people in the room and so on and so forth. Are you referring to people within the community that will engage with the initiative, to a large extent? Or do you mean stakeholders and people that can provide those resources in those resource-scarce communities, or is it potentially both?
It's often a bit of both. We had quite a few discussions around a concept. There was a nutcracker model, but essentially how much top-down support do you need and bottom-up energy in order to push, have momentum and push forward. I think, if you have a lot of community will but not a lot of stakeholders who maybe have access to the purse strings or the expertise, is you have enthusiasm but not enough drive. And if you have all the people with control of the money and the expertise but no community engagement, then you don't get the energy either. So it is a bit of the dance of the two things. That said, you don't have to have the perfect person. And the initial coordinator for Our Healthy Clarence was a local businesswoman. She was quite entrepreneurial and she was amazing. She was very connected, very prepared to have conversations, and she really bridged between those two groups very well.
Yeah, I mean, it seems from reading your article, it looked like both components were quite vital to the success of these kinds of initiatives.
Yeah, if you want to get to long term, like if you want to get to something that survives more than a flurry of interest or a short-term grant and things like that, the ones that, which is why we were trying to capture those that had a bit of duration under their belt to have a look at saying what made the difference.
Okay. Now, were there any borderline cases, like communities that almost made it into the study? And if so, what distinguished them from the ones that you selected?
Okay, I can speak more in terms of my experience with working with communities than in the review, because we had to apply a particular criteria. But what I can say is there's a real aspect around community readiness. So if you think that there's sufficient interest, that there is a group of people who are willing to work on it, that they can see opportunities on where they might address things, you need a certain level of appetite in the community to address the challenge at hand. And that seems to be a factor. We got to work with Margaret River, and one of the things that struck us when we were approached to come and talk with that community and do a similar thing that we'd done with Clarence Valley was they had two amazing and comprehensive community wellbeing plans from the council, and they were 1 year after the other, and yet nothing had happened, and yet they were they were sophisticated, they were comprehensive, like you thought, well, just go. But you also need that impetus to drive the work. And I think with a few other community members and interest groups, there was a local philanthropic health foundation that had seeded the funding that caused us to go across. And after that process and doing the same sort of report, they really kicked off, and they've got a Mindful Margaret River initiative that's still going. So sometimes the effort is a latent investment because you've got that knowledge there, but you need certain things to get you going. And I wouldn't think the other things are failures, but it's like an insufficiency, if you know what I mean.
Yes, no, absolutely. Now, did you include grey literature or reports from non-academic sources like community reports and project evaluations in your search? And why or why not?
Okay. In the second one, it's straight out academic papers. But in the first one, our scoping review, we used Google Scholar, which has a reach into the grey literature space, and that allowed us to look at various things in report form and that kind of side of things. And base of work, I would actually advocate, if people are reading, do go into the community reports and things like that. One of the things about in my when I was working at the Centre for Rural and Remote Mental Health, we made it a very deliberate act to make as much of those kind of reports as public as possible, as long as the communities we worked with were happy with that, because you're often working with people ahead of research ethics and the slowness of what academic papers can do, and yet being responsive and engaged is probably more meaningful than, asking a community that's potentially ready and maybe responding to concerns or crisis, just we've got this research we'd like to do. It's not quite the same thing. So I have a great value of the grey lit, but it didn't make it into the second review. For what we wanted to do in the second review, aside from showing people how it worked, was, given the nature of the work that we had started, we had been approached by the New South Wales Mental Health Commission to find evidence in this space. New South Wales Health was willing to invest in this. And one of the things when you're working with government departments is they really want the evidence to be strong and to be careful. So that's why we restricted to the academic literature space, so we could say, hand on heart, this has all been done rigorously, this is what you can do, and this is what we came and found.
To what extent do you think the lessons from these exemplar communities mentioned in the study, to what extent do you think that those lessons are transferable to, quite different contexts, like from high resource to low resource settings?
Oh, definitely. I think for one, the exemplars in the paper are actually really varied in their level of resourcing, and you can tell by one of them. I think we covered over Thrive New York, and it had, I think, 14 papers, if I'm getting the right one right. And, our Healthy Clarence has one paper. It's one little bit of attention, and I think it was a terrific initiative, and it was fairly low-resourced. I have had the opportunity, I've had an honours student go back and interview a number of other community wellbeing initiatives globally to see if the framework holds up in other contexts. And it does, which I'm very happy about. But that was also a different range of initiatives that came up in that. So I think it does hold. Obviously, when you've got more resources, it can be easier to make your progress visible and things like that. Like, I think one of the things that happens is I think there are communities that do very well and we never hear about them, which is one of the shames of over-indexing on the research. I think capturing some of those would be really good. One that I didn't get to do, but I think is really interesting because I heard from them was, I'm going to get the name wrong now. It was in the US, a local community, collaborative to stop services being discontinued in their town and to ensure that they were attracting, health workforce. They essentially formed their own not-for-profit and over time had done not only things about, recruiting and retaining things, but had worked on, active transport in their community. So there's these lovely bike paths and all sorts of things that over the 15 years that they've been running has turned it into a place that people want to come to, and they've really got a strong sense of their own agency around things. So wow. I think sometimes these things can morph into quite sophisticated and helpful community-based and led, whether it's an organisation or still a coalition. Yeah.
For communities that might be scarce on their resources, we talked about that community involvement and, people really coming together to get these initiatives to stick and that sort of thing. But are there any other things that communities can implement to overcome a lack of resources?
Yeah, I think asset mapping for one, identifying what you already have and how you can leverage those strengths is really important, because sometimes bridging the gaps requires you to sort of work with what you have and then find more. I was looking at my link to the community wellbeing paper today and I realised I need to link in some additional resources because the Centre for Rural and Remote Mental Health's website is now archived, and I've got all these public resources that I'll upload. So at the end of today, I'll make sure they're on there. But there's just a little bit of resourcing around some easy sheets to say how to measure and watch how your collaborative's going, how to look at how your community is going, and thinking about the mechanisms that you might want to organise yourself by. So there are some tools and there are some resources that you can look to, and I'll share those with you, Guy. But I think for the community is that getting together, looking at what you already do, and sometimes that sort of asset mapping is really quite a helpful thing for a community to go, we're not completely without resources. We do have things, and how do we make the most use of that? And for the things that you realise you are missing, how do you coordinate and advocate to your local member, to your local government, and address it? And if you've got data and evidence to say, that's really helpful. So I guess if I reach back to Clarence with things that happened with them, unfortunately, I remember they ended up on the front page of the Telegraph. And it was really dispiriting for the community because it was all crisis and, very inflammatory, and it felt kind of defeatist. But one of the things that happened as a result of that was the then health minister, he turned up, basically, flew in by helicopter. What do you need? And they had their evidence review already, and they went, well, we need youth mental health services, we need this, we need that. And they were able to leverage some practical investments that they couldn't have done so convincingly had they not been looking at their own data and pulling some things together. So, yeah.
So we've talked about some barriers already. Are there any other, common barriers that communities face with implementing these kinds of initiatives that we haven't already covered?
I don't know, but I guess I'm sort of thinking about other things that you can do in the main, just to get back to your previous point. Some things that can be done and should either be very low cost or no cost would be thinking about building the health and wellbeing literacy of your community. And if you can gather the people into groups, there's lots of organisations that provide training. I think mental health first aid is a little bit too much, can be quite long, but there are shorter courses that can help people understand what good health and wellbeing looks like, what the signs of ill health looks like, and how to get to services. And if you live in rural New South Wales, we have the Rural Adversity Mental Health Program, and there are 20 coordinators across rural and regional New South Wales, and they provide free training in this space and can really help. So I think reaching to where there are public resources and sources of help would be really a good place to start building knowledge and building appetite for change. So that may be something to think about.
Now, earlier you mentioned, that top-down versus bottom-up, those two different sorts of approaches. And just to clarify as well, bottom-up is sort of when you start with consulting the community and then you build the initiative based on that, and, community
or the
champions.
Community come to the others saying this is what we want. Yeah.
Okay. And then the top-down is an external group of people has this sort of design or this vision for an initiative, and then they are sort of the catalyst for the implementation of that in the community. Is that right?
Yeah, or they may come with money and a particular view of how it should be spent.
Yep.
And I think if the community is savvy, you can often leverage that and say, thanks, but we'd like to do it this way, and this is how it's going to meet your brief. I think one of the challenges of if you have evaluation that's not that imaginative is, a more accounting model, they will want to know how it prevents suicide or how it does this, and you need to sort of be able to show, we will do these things in this way, and this is how it will address your concerns, but we're going to frame it in this way, in this sort of strengths positive framing, because we're going in the direction of travel, not what we wish to avoid. And we do this in other areas of public health and safety. So if you think about driving, we don't call it collision avoidance, we call it driving, we call it driver safety. So there's a fundamental thing around being able to take opportunities, but to work with those players who are, going to bestow the resources to you about how you'd like to use it.
It seems like it might be kind of a difficult thing to balance that aspect of community ownership and community involvement in their say with that external support, investment from external stakeholders and so on.
Definitely. I think it is really tricky, and it takes a little bit of, that's where some of having good relationships with, local leadership and into the services can help, because if they become champions of it, they can really advocate and be a strong supportive voice for it. If I go back to the Clarence Valley opportunity, I know that there was challenges with them getting some monies that they would have been able to use, but there was a lot of pressure to say, could you just call yourselves a suicide prevention network? And they were saying, thank you, but no, we'll rather go it alone than that, because of the nature of the messaging and what they thought they were about. Yep. And also then that collapsing view when you said why not just the clinical things. And I think the clinical things are really important, and there have been investments in the last 10 years, which is so good to see, things around safe spaces, safe alternatives to ED, things about more postvention, more things. But in the main thing, keeping a community healthy and well, keeping and building the literacy of a community around health and well-being is vitally important. And also the community level one for me is about understanding that it's not just on the individual to ensure their own happiness. The elements of what a good, strong, supportive community is, that the social connectivity and ties and support is incredibly important for an individual's mental health and well-being. Yep. The structural elements we can do to support people to have happy and healthy lives and can go out for a walk and things like that, they're collective things. And so I think sometimes when we get focused on the individuals, we forget how much of the collective responsibility and impact and importance of those things to keep people well.
Absolutely. I think you've hit the nail on the head there. And what are the most prominent gaps in the research in this field of study, and what do you think future research should focus on?
Look, I think for me, a bit like my rural health work, is it would be great to have more cases, to go into communities that are doing it well and having some of that more the historic lens and pull back and be able to do things, to be able to work with communities and come back. Not all of them work, and actually sometimes when things fall over, people are reluctant to talk about it, but actually there's a lot of value in learning from those moments. But I guess one of the things I'd caution with that is, because you can get into deficit view, is often the opportunity to come back is an opportunity to renew your efforts and your focus. So I think over time it would be great to work with a number of communities around how they're going and how they conceive of it and that kind of thing. So that would take, patience and resourcing to do that. In terms of other gaps, I think your previous question around how hard is it to prove the thing, especially we're in a time where there's lots of short-term funding sources on this sort of work where we go, we know it's difficult, we're all stressed, let's give you 2 years. And I think that the real difference will be where there are longer term investments and they can actually look over time. But I would counsel that anyone interested not to wait for the proof, but rather to get along board. There are 2 that I can think of where there is some long investments going, and I think we mentioned it in the paper, but the Hogg Foundation in Texas actually is funding 5 rural communities over time. They had a 3-year planning and engagement phase, and then they have followed by a 5-year investment with a rolling further 5 years after that, should all things go well. So that should have a really long lens on how things work. They are, of course, learning that community readiness piece is really important, how to keep engaged, what to do, like all of those things are living lessons. But they're actually advocating to other philanthropic organisations going, come on, get braver, invest for longer, do it like you really mean it. So that's exciting. And in Australia, there's an Our Towns initiative in South Australia. It's the Faye Fuller Foundation funding that, and they've got a longer-term lens on how they're supporting communities to do more of this work.
That's awesome. Well, I think it's a great cause, and it's doing things for people in communities that need it, so that's fantastic. Yeah,
I agree. But I get to do the thing of reporting on it, not the hard yards of what the communities are actually doing.
Well, you're still bringing something to the table and doing something that's very much needed, so good on you for that.
Thanks very much, Guy.
Not a problem. Thank you very much for joining me on the show today.
No, it was my pleasure. Thanks for the interest.
Not a problem. My guest today was Dr Hazel Dalton from Charles Sturt University Orange at the Rural Health Research Institute. Thank you for listening. I'm Guy Murphy, and all of us at Wellbeing wish you well.